Welcome to Slay, the podcast where we dive into all aspects of female health, fitness, and life. I'm your host, Louise Hazel, and in today's episode, we'll be diving into whether exercise is doing us more harm than good. Joining us today is an athlete who's dedicated his career to helping individuals achieve their fitness goals and recover from life-changing injuries. With a wealth of experience in personal training spanning over 18 years and a deep understanding of injury rehabilitation, he's transformed the lives of many clients, guiding them towards improved health and well-being. In this episode, we'll explore his journey into the fitness industry, the core principles that drive his training philosophy, and how he tailors his programs to meet the unique needs of each individual client. We'll also discuss common injuries, effective rehabilitation strategies, and the importance of injury prevention in maintaining long-term fitness. So, whether you're a fitness enthusiast, someone recovering from an injury, or simply interested in learning more about effective training and rehabilitation techniques, this episode is for you. Get ready to be inspired. Joining us today is the creator of Infinite Athlete and the owner of Boa Fitness. It's Rua Gilna. Rua.
Rua. Hey Louise, how are you?
I'm great. Thank you for joining us. What a pleasure to have you on.
Thanks for having me.
Thank you. We'll dive straight in. Rua, take us right the way back. Talk us a little bit about your background. You know, a former athlete yourself. You've pretty much done everything: MMA, gymnastics, breakdance, and literally anything that can hurt the body. But how
all the dumb stuff.
Exactly. Anything where you're just like throwing yourself around and throwing other people around. But how did you get started in personal training and injury rehabilitation?
So I have to kind of go back to, I obviously started in athletics first and sports. When I got to college, this is a funny story. It's also a very, very Irish story. When I got to college, they just changed the licensing laws in Dublin and in Ireland in general, whereby you had to legally have an ID. The drinking age, for those of you who don't know, in Ireland is 18 years old. And I was just turned 17 going to college.
Mm-hmm.
So my first entire year, they just cracked down the licensing laws. We had to carry your ID, so I couldn't get in anywhere. So I was like, okay, well, everybody else is off, drinking and having fun. I guess I'll take up some sports. I hadn't really done much sport before that, a little bit here and there, but nothing crazy. And my first year, I ended up winning the gymnastics nationals on the college taekwondo team, judo team, snowboarding a lot. I picked up Ming Chuan Kung Fu. I kind of just snowballed from there. I ended up competing in a bunch of different martial arts. I still competing at breakdancing. I still compete actively. I just won the New Jersey, the blue belt level, won the New Jersey Open for Brazilian Jiu-Jitsu, my own weight category. First fight finished in like 14 seconds, 15 seconds. I've been lifting weights forever. I've got like elite powerlifting total. It's just lots of stuff. I can't sit still. That's the biggest issue. How I got specifically to training was, in that first year, I was spending 35, 40 hours a week doing sports and training. Well, my plan was to go through with finishing an applied physics degree. And I realized that my friends who were going the whole way through the degree were working as actuaries, were working in banks, working for large tech companies. And I realized that I would go absolutely insane doing that. So I decided, okay, well, let me go into something that I care about. I can always go back. For those of you who don't know, education is free in Ireland. Yeah. So if I want to go back to college, it's not really a big deal, not getting into debt by doing it. So I dropped out and started going into personal training, and everyone laughed at me at the time. They're like, that's not a great career. Mm-hmm. And it's 21 years later now, and I'm still doing it. I'm still loving it. And sadly / fantastically still learning as well. Mm-hmm. That's kind of the basis of it. There was a point where I thought I'd be one of those like aerobics presenters that are big in Europe. And then like I looked at the reality of it, I thought, absolutely not. I would shoot myself in the face.
Yeah, there came a turning point as well, I think, for me a few years back where I was like, I think the more you know about fitness, the more you know about training, the more you believe in yourself as an athlete and believe in others as an athlete, the more you can kind of step away from like aerobics and any form of nonsense like that.
Exactly.
I read online that you said personal training is not just about fat loss. If it's not about fat loss, Rua, tell the people, what is it about?
So for me, it depends on the person. I got a lot of professional athletes that I work with, and for them, it's about performing on the day. It's about performing optimally. It's about putting, food on the table, making money within a very short span. You're a competitive athlete. You know this. You've got a very short competitive span, after which point you're not going to be able to keep up with people. For some people, it's going to be 5 years, some people 10 years, some people 12 years, but they got to get it done within a very short time frame. So for them, it's all about specificity. For basically everybody else, as far as I'm concerned, with small exception, it's about living your life and feeling good and not making the gym your life. The fitness should improve your health span, but not become and, take over your whole life. It should be, I'll get in, get my session done, feel good, live a great life, feel fantastic, play with the kids, be able to walk around, be ambulatory when I'm 85 years old, be able to go gardening. I've noticed it gets a big contrast between Europe and America when I moved over here. A big thing was Europeans travel when we're young. We travel in our 20s, we travel in our 30s, we travel in our teens. In America, a lot of people, not us, changing generationally, but a lot of people travel when they're older. And you'd see busloads, elderly American tourists, and they can barely get off the bus. And my whole life, I remember seeing that and going, well, if I'm traveling when I'm older, I don't want to be barely getting off the bus. I want to be hiking up the side of a mountain. And getting that health span, not accepting the kind of cliche, the pain and lack of ambulatory function, the inability to walk around is something we can't avoid. We have to just book that trend. It's not an acceptable thing. And unfortunately, it's just accepted far too often. It just doesn't have to be that way at all.
Now, talking about pain, I want to get straight into it. We actually asked our audience on social media yesterday if they were in chronic pain right now. And of those that answered yes, 45% of them said that they were suffering from lower back pain. And 75% of those people were not in treatment for their lower back pain, stating that they just didn't have time or they were just going to ride it out and see. Now, what do you have to say about that? Being a man who puts people back together for a living.
So for me, again, it's going to be a mixed bag. I tell people all the time, life is not fair. Some people can do the dumbest things in the world and just never get hurt because they were born resilient, they're genetically resilient, they don't have trauma, they're just lucky, whatever way you want to frame it. Some people just don't have that. Other people will sit and do nothing and not put any load, not take any risks, and they'll get hurt. And life isn't fair there. So for those people, I would say a couple of things. Number one, if you're doing something and you've been doing it for 6 months and it hasn't made you better, the chances of making you better now are basically zero.
Break that down.
To the definition of it.
Give me a prime example.
So I'm not going to roll. When I say this, I'm not trying to be critical of physical therapists because I work with a lot of phenomenal physical therapists. But I have seen a lot of people coming through physical therapy out the other side with no measurable, appreciable change in how they feel or how they move. A lot of times, and again, I'm talking America specifically, the physical therapy model here, it's very much like a kind of a factory model. They'll recruit young, inexperienced physical therapists, not always. And there are phenomenal physical therapists in network in these places, in some places. I'm talking in general. They'll get young physical therapists who are inexperienced and they'll be seeing 10, 15 people an hour. They don't actually get time to assess a human being, to actually see what's wrong with you, to see what's wrong with your joint. They say, oh, it's a shoulder issue. Well, I have approximately 3 minutes to spend with you. So here, do these shoulder exercises. They have no idea whether or not these are the appropriate shoulder exercises, the appropriate low back exercise, whatever it is. There's no actual treatment and individualization in this person's program. It's just been, I'll throw enough nonsense against the wall because my workload is so high, I don't have the capacity to actually help this person. It's not possible. And to their defense, and I really am trying to defend them here, it's not their fault. If you gave me 5 to 10 minutes of somebody, I probably couldn't help most of them either. Like when I work with somebody individually, I'm doing an hour to 90 minutes for a session. Most of it's just assessment and history. So to have 5, 10 minutes or less and then be handed off to a physical therapy assistant who by and large have little or no qualifications to do a program that's in no way individualized. Yeah, it's kind of like a losing formula. Like, I don't think anybody really expects it to work, but it's a broken system that a lot of people are graduating into the industry with the hope that they won't have to do it this way, but they have to do this way until they're experienced enough to actually go out on their own and build a client base or find a private practice. And then there's also, they have to overcome the stigma that a lot of people won't work in network because it's cheaper because their insurance will pay. But a lot of time working in the insurance network means you're going to be stuck with these places that have a lower copay and that the insurance can pay less. So you're going to be stuck to work with these new guys who have no experience and again are stuck to this kind of model of I'm seeing 6, 7, 8, 9, 10 people per hour. So that's the big thing there. So from a purely fiscal perspective, a lot of times going to a really good therapist or a really good body worker will cost you less long term than going the cheaper route.
Got you.
A lot of people I work with, for example, I've seen 3, 4, 5 times. If it's a simple low back issue, I'll see some people virtually 3, 4, 5 times, and they never have to see me again. And sure, it's not a small amount of money because I'm not cheap. But if they're going to physical therapy 3 times a week for a year, 2 years, that's going to be way less than they're paying me.
How much are we talking per hour here? Give us
At 200.
200. Got you. So,
Yeah.
someone basically invests, let's say, 5 sessions, $1,000 to fix their back, but never have to walk
Yeah.
through the door again. And if you're sending that person to a PT assistant, how long with the same injury, over 6 months, what's it costing them in terms of their insurance, in terms of their health plan, in terms of their long-term health?
It wildly depends. Like some copays have $30, $40. Some insurance have a $30, $40 copay. So they'd be paying $120 a week for 6 months.
Yeah.
So now we're into like around $3,000. Now might go into next year, so it might be on $6,000, and then they might have to go again the year after, $9,000. But more than that, I think most reasonable people would pay $1,000 not to be in pain for 15 years.
Absolutely.
My mother-in-law, for example, my wife's mother, she was she had a couple of disc issues. I'd seen umpteen physical therapists, like I don't know, in the teens for sure. A couple of surgical consults. They wanted to do a disc fusion or discectomy. She said no. When myself and my wife had started dating, I said to her, "Oh, well, I do some of that. I don't want to get into it. I do some rehab. So, if I ever meet her, I'll have a look." Within 30 minutes, 35 minutes of meeting her, of the assessment, I was like, "Hey, we're going to do 2 exercises." This is off just 2 exercises. It's about 2 minutes, 3 minutes of work. She says, "Oh, it doesn't hurt." Now, it doesn't stay that way for a while until you pat on that. But she had been through over 6 full years of physical therapy, on and off then a couple more years, had several surgical consults, had worked with probably a dozen different physical therapists. And again, I'm not trying to denigrate physical therapists here. If you're working in that setting, it's impossible to have the time to work with somebody properly. It took 30 minutes.
So where is the system failing us? Like, where is it going wrong? And why are we getting
insurance
prescribed in this surgery thing,
Oh, well, yeah.
Why are we over-prescribing medication, surgery? I've literally just recovered from a broken arm, like however many months ago. I can reach above my head, didn't have surgery, had an amazing physical therapist, Chris Gerona, shout out Chris.
Fantastic.
Honestly, as soon as he put his hands on me, we did a 90-minute session. Our sessions would sometimes go on for hours, like you say. I was like,
that's exactly what I'm talking about. Yeah.
It's another level. Unfortunately, with my background in sport, I know what good therapy is. I know when someone's taking their time. I know when they're paying attention. I know when they're distracted because they've got to see another client, like you say, in 10, 15 minutes. And I was very, very lucky to come across Chris and to have that referral. Because the amount of time, care, dedication that he spent with me, literally restoring my shoulder, 5 months later, I'm able to do my first pull-up. And I didn't.
Yeah, that's wonderful.
Do that for a year at least.
Yep.
So where are we going wrong? You said, you said insurance, right? So what's going on there with the insurance that is not serving us as the average person?
So, like, if you're a good physical therapist, like if you're good in anything, or a good trainer, or a good whatever, you're going to want top dollar for your services. If you got 20 years experience, you're not going to take the same as a day one person. It's just, of course you won't. A lot of insurances, they'll negotiate the payments down. It's also the whole insurance system in the USA. You're not American. It's wild. Like the medical costs here are just so far out of control. It's insane. With the insurance system here, that most people don't want to pay out of pocket, which is very understandable. So they'll use their insurance because that's what they're paying for. The insurance will basically I've never seen it cover good physical therapy. It just doesn't. It just doesn't cover that one-to-one patient client or patient doctor model. It just doesn't do it. So it's basically like, hey, either pay out of your pocket or the money you're paying for insurance for this purpose is useless. That's part of it. Another part is they'll go to these, again, typically young, inexperienced physical therapists. They'll be there for 6-9 months and get no relief. So then it's like, well, okay, we've tried everything. No, you haven't. Not even close. You haven't even been assessed. You haven't had it. Like, if you haven't been assessed, there can be no logical intervention.
Are we just looking at pain management a lot of the time when we're getting physical therapy treatment, or are we getting to the root?
Not even. It's just like, hey, literally what happens to a lot of the people that I've worked with is they go see someone, they say a body part, they get thrown 2 dozen or half a dozen exercises, anywhere between 6 and 24 exercises. hey, do these. But let's say, for example, you got a rotator cuff injury. Let's say your internal rotators are too tight, your external rotators are too long and too weak. They'll have you do both. Every person with shoulder injury gets this. I'm like, well, it can't be both. You
Yeah.
can't be both. You can't be long and weak in both of them. So why are we doing both? There's no specificity to this.
It's going to be
You know
one
what I mean?
or it's going to be the other.
Exactly. So why are we? What the different stories? You have a dislocation. If you have a trauma injury, in that case, you may need to do both. But if you have a chronic, ongoing kind of niggle of pain that's growing, there's something ongoing and chronic that needs to change. First of all, so we have to assess what you're doing, what you're loading, how you're lifting, are there daily habits and positions that you're putting yourself that are a problem, and then we have to see where is the weakness, what's tight, what's loose, what's weak. We have to be very specific and almost surgical with our intervention. You can't just go, try it all, because trying it all is kind of how you get there in the first place. Lack of specificity.
What do you think is what's the most common complaint that you get from personal training clients, and also obviously physical therapy clients? What's the most common injury you encounter?
The two big ones would be low back pain and typically right shoulder pain, especially by anybody who bench presses.
Where's that coming from?
So the right shoulder pain is an interesting one. We can tie it into low back pain as well. Mm-hmm. First of all, I'm sure I'm going to get some abuse for this. But if anybody doubts my bench press credentials, I can do double body weight plus. I can do my own body weight for 20 plus reps, full range of motion, no arch. And I can lift more than almost anybody who's going to try and make fun of me.
Give me
that, however,
tips.
Never. How about this? This is going to annoy some people. Never arch your back in the bench press unless you're a competitive powerlifter.
Mm-hmm. Why? What is that generating for general population that it is not impacting our top level bench presses in the same way?
So let's talk about it for a second, right? So our powerlifters, again, this is not a criticism of powerlifters. I work with a lot of competitive powerlifters on rehab and performance. For powerlifting, the goal is to get the bar to touch your chest. So the higher your chest is up, the less you have to push the bar. It's very simple. Yeah, if I arch my back here, now all of a sudden I only have to move the bar 8-10 inches. If I'm tucked pelvis, flat back, now I have to move the bar 2 feet. So mechanically, it's much more difficult to actually use that full range of motion. However, what's going to happen is when we arch the back, what's also going to happen is the rib cage will externally rotate and like so. Okay, so you're going to get a protraction of the ribs and they're going to externally rotate. That's going to mechanically lengthen a pec, first of all. So you're going to have a higher incidence of pec tear. Now, of course, powerlifters tear the pecs every now and then because they're lifting huge amounts of weights, not to mention the PEDs associated with the sport. And again, it's just, huge amounts of weights, but it's going to increase the incidence of pec tear. Now, if we're talking about pec hypertrophy, we're never going to get a fully shortened pec if we have a stretched position in the pec in the first place. If the rib cage is pulled out in this arched position, you can't shorten the pec fully. It's literally impossible. The humerus has to come forward and across the midline or close to the midline, or at the very least forward and protract the scapula to an extent with a couple of other muscles to actually get a short pec.
You can actually really feel that when you do it as well.
Yeah, if you do like a cable chest press, for example, and bring them together, you'll really feel that. You can't get that contraction with an arch back bench press. Again, it's necessary for powerlifting, but why would general population train like powerlifters? Mm-hmm. Do they want to move like them? Mm-hmm. Do you want to look like them? No, so we owe a debt of gratitude to powerlifting and bodybuilding for popularizing weightlifting, but we need to move away from that into much more athletic-based movement, giving people the ability to keep moving as opposed to making them, rigid. Like nobody ever looks at a powerlifter and bodybuilder and says, that's a person that looks like they could do a backflip or climb a mountain or go for a run.
Right.
The physique is specific to the sport. On top of that, and you can test this yourself, anybody watching this, you can test this. So without getting too much in the weeds on pure biomechanics, right? If I'm here like this and I arch my back, if I let my humerus, my arm bone, go with my chest, as the rib cage externally rotates, I would walk around with my arms like this, out by my side. That's not going to happen. So what we will do unconsciously is internally rotate, which we talked about, internally rotate the arms so that doesn't happen. But that now means we can't internally rotate it any further. So let's say if I'm sitting here nice and normal, I bring my elbow up here, I can rotate my arm down without this coming up, my trap coming up, and my clavicle rolling, about 90 degrees.
Yeah.
70 to 90 is like a great range of motion there. If you can get 70 to 90, you probably don't have a lot of shoulder issues. If you're finding like this happening before 45 degrees, you probably got some issues. Okay? And that's okay. But now if you arch your back and try the same thing, you're going to have 5-10 degrees tops.
Oh, wow, yeah.
Because you've already used up the internal rotation.
Right.
Now, if you're bench pressing, You have to internally rotate to bring that bar down. So now we're loading rotators. We're trying to let rotators do the job of pec, which is a stretch inhibited position. We're asking to do something else's job.
As opposed to prime movers.
So, exactly. And the same thing for, if you do this, humeral abduction, right? You can see here I have about 180 degrees of abduction. As soon as I arch my back, that goes to about 15 degrees. Now, we need 30 to 45 degrees to bench press well. So again, we're putting ourselves in a position where we're loading ligaments, loading tendons, loading smaller muscles and asking them to do the job of a muscle that we've overstretched to cheat the range of motion for the sport. And then we're telling everybody else, hey, this is the way you should do it. And especially, I'm going to call guys in the gym out here as well. Guys love lifting heavy because it makes them feel more manly. Guys, you don't have to lift heavy. You can do high reps and still get hypertrophy, still get size gain, still get strength gain. Full range of motion with a lighter weight for high reps. You'll still get big and strong, but you probably won't get nearly as hurt. It's fine. Yeah. No one cares how much you lift. I can't
forget the guy.
Guys always go to the gym. They think everybody cares how much they lift. The only people that care are other bros. That's it.
And the girls at the Slade gym here in Hollywood.
Yeah, no. Don't get me wrong. I like when my clients get stronger, but like nobody's judging them if they're not benching 315 pounds.
Yeah.
Yeah. Nobody's like, oh, that's terrible. They're like, oh, well, he's here benching, so great.
Yeah. What's better than what I was previously doing? Amazing. What do you say to those people? So let's say your client comes in at the weekend. We're going to take it back to back pain. They've cut their back. They've been in the garden all weekend, but they're still turning up for the session. Let's say on Monday morning. What exercises are you sending them home? Like,
no, almost never. So that's actually a really good question. If somebody comes in and sorry, go ahead. I interrupted you.
If you're not sending them home, what exercises are you giving them to get through the session that day?
Perfect. So the first thing I'm going to do is I'm going to assess. It's going to be a brief assessment because I already have a full assessment for this person. So I know what the baseline looks like. I can almost always guess what the issue is, but I'd still rather have data because we all have biases. So I'm going to do something simple like a straight leg raise test and a PRI test called a Hruska adduction drop test, or physical therapists might know it as an Ober's test. The first one is I'm going to have people lie down their back and basically see how far they can bring their leg up this way. Nice and easy, right? Now, when you do this test, some people will think more is better. More is not better. If you're going past 90 degrees comfortably here, you probably have some lax ligaments in your hips, either the iliofemoral or pubofemoral ligament. If you're a past athlete, like you, like me, you'll never lose that flexibility. Even if you gain control, reflexively, my leg will stop here. If I want,
woo!
it goes off camera. I can still do splits. I'm almost 40 years old and I don't stretch. No, it's going to piss somebody off, but I don't stretch. We'll get into that later. But so if you're going less than 90 degrees, I'll see if your hip can drop in what's called an Ober's test or an adduction drop test. I move you guys back so you can see a little bit. Now, typically this will be done by somebody else. I'll do this on the client. Get them on the side. And of course, I'm wearing black pants, so you can't really see much. But you're going to lift this leg up. You're going to bring it behind them, and you're going to drop it down without this hip deviating too far this much. What that's testing, can your leg come across midline, right? If your leg can't come across midline and your hamstring will go, that means you're stuck in an untucked position. Basically, your pelvis is anteriorly tilted on that side. It could be on both sides.
Stand up, show us exactly what that is.
Sure. So, pelvis anterior tilted here. Yep. So you're going to get this roll forward in the pelvis. I have a pelvis here. Right? The reason I care about that is because when that pelvis rolls forward, here's the thing that I wish the fitness community knew more about. Position dictates tension. We have this idea about mind-muscle connection. I have to consciously squeeze the muscle. So you're an athlete. When you did any of the events in your heptathlon, did you think about a single muscle you're using?
Absolutely not. No.
No, of course not. Why would you? There's no way you could. You don't have the time to do it. So position dictates tension. We do the thing, we position ourselves, and the shorter muscles will take the weight. Now, when you anteriorly tilt the pelvis, when it rolls forward, and I cannot stress enough, it's not an evil position to be in. It's necessary. If you're jumping, you have to anterior tilt the pelvis. If you're walking, the side that's swinging through the air will anterior tilt as the other one goes backward. And then they'll swap, and then they'll swap, and then they'll swap. Which will look like boop, 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 like this, right? One side will go back, one side will go forward. If they're both stuck forward all the time, which happens to a lot of people for a lot of different reasons, a lot of fitness stuff will actually cue that to happen. That's a whole other conversation. Then you have two erectors, two low back muscles, which are always on. They're getting crunched the whole time. And what you're going to get there, and if you guys are following fitness stuff nowadays, there's a lot of kind of talk about injuries, and you can't predict injury. Sometimes you can.
Yes.
Sometimes you absolutely can. One of the biggest predictors, they found in this huge study, they found that essentially if you look at a muscle that has pain, you'll usually find low available oxygen in that muscle. There's a couple of different reasons we're going to have that. But one of the biggest reasons, that muscle's hypertonic. It never gets to turn off.
Got you.
So for that person, if their leg, say for example, is coming up to here, right? They can't get all the way up to 90 degrees. The low back is on. They can't cross midline. I know, and visually I can see it as well, but I never rely on visuals. I always test. I know the pelvis is anteriorly tilted. And here's another part of this. I'm not going to get too much in the weeds. When the pelvis anteriorly tilts, the femur wants to come away from midline and externally rotate. So it'll come away and externally rotate. When it posteriorly tilts, when it tucks under, it wants to come towards midline and internally rotate. Those three movements on both sides always are worked together as two kind of triads of movements. So I know, for example, if they can't adduct, that test I just did, then there's no way they're stuck posteriorly tilted. No, it's tucked under. I know they're stuck anteriorly tilted. Okay, cool. So what we're going to do, counterintuitively, and I see this all the time, they can't, their hamstrings feel tight. They can't get past here. A lot of people are going to say, okay, go stretch their hamstrings. I'm going to say, no, absolutely don't. Shorten their hamstring. And people get really annoyed by this. Like, what do you mean? That's so stupid. I'm like, let's talk about it. So where does the hamstring connect? So the hamstring goes, crosses the knee joint, comes the whole way up and connects to the posterior part of the hip, right? In and around the ischium here, we've got a couple of different connections to the hamstring. If this rolls forward, boop, like this, does that move further away from the ground or closer to the ground? It goes further. Yeah. So the hamstring gets longer. The hamstring gets mechanically lengthened, and all of a sudden, the brain goes, stop lengthening it. You're going to tear it. So it makes it tight. The Golgi tendon organ and the muscle spindle kick in as a protective mechanism. And us, being the dumbasses we are, we're like, oh, it's tight, I'm going to keep stretching it. And the brain's like, stop. Stop. I keep tightening it up so you don't hurt yourself. Stop stretching it. I taught, so I used to be the head of education and training for this large company in New York City. I had maybe 200 trainers under me. The minimum requirement to be hired was at least 5 years of training, and I preferred significantly more than that. But I had 70 roughly trainers in the room. I was giving a seminar on the kinematics of the pelvis one time. And I said something about stretching and how I'm just not a big fan. There are times it's useful, but for a chronic issue, it's very often just not that helpful. I could see people in the first couple of rows, and they're like, I was like, okay, well, let's address this really quick. So we had 70 plus people in the room, at least 350 years experience, probably 400 plus. I said, hands up, who's ever seen someone get more flexible from stretching after puberty? 0 hands went up. I was like, great. So does it work? If you have to stretch every day, all stretching is inhibition. It's taking leverage away from something. The way the body works, if that is always tight, let's say we're standing up, the low back is always tight, it's always on. It's doing something else's job. If we just turn it off and don't turn something else on, we'll default back to that. So we have to, when we posterior tilt this pelvis, we have to find a way to make the hamstring hold us up and use it against gravity instead of low back. We have to learn how to switch positions, and it's not as simple as stretching. It's not as simple as foam rolling. It's as simple as learning how to well, it's not simple at all, but it's it's learning how to repattern the brain to automatically use certain muscles.
So what
a great exercise.
Doing if someone's in that anteriorly
the anterior pelvic tilt.
Yes. What exercise are you giving them? They've come in. They're all
the most boring ones you've ever seen. They're so not sexy, and everyone hates them. And they're like, I don't want to do this, and they do them like, oh, I feel great.
Top 3, go.
It's my top 3 hook lying position. Right, this is the most boring one ever. I'll put like a block or a pillow between the knees, have them lay down like this. Scoot down so you guys can see me. They'll tuck their pelvis. No significant force involved. And here's the kicker, right? They will, throw my big hobbit feet on here. They will put as much weight as they can on the outside of their heel. They'll keep contact at base of pinky, base of big toe, and pad of big toe. What that will do, if you're a flat-footed individual, it will give you an arch immediately. it will automatically and reflexively turn your hamstring on and turn your low back off. I'll have them sit there and breathe for 30, 40 seconds, and most of them will pass half the table test they couldn't do beforehand, and will stand up and sense a change. That is number one. I do that with almost everybody because almost everybody's going to have back pain at some point. Now, to get that to stick, we have to integrate that same position to a couple of different movements. It's a little more complex than that, but that is a great start. And if anybody doubts me on that one, you can try this at home, guys. You can stand up on one leg, maybe on both legs, shift your weight to one side. You're not going to see this happen because you can't see what I sense. But you shift your weight to one side and try to get as much weight as you can on the outside of your heel without letting that ball of the foot come up, and touch your hamstring. It'll turn on. Low back will turn off. So if you're someone with low back pain, that's something you need to learn how to do. The next one I'll do, it's a very, very simple movement. It's an all fours position. And I did a modification of this in my jiu-jitsu club a couple of weeks ago, and everyone started laughing at me. We did this all fours position. Then we did push-ups from here. Bunch of big, fit, strong, athletic guys. I don't think anybody get past 8 or 9 push-ups before they face planted. Wow. Because this specific way to do a push-up uses serratus anterior. Ugh. It uses the oblique. Yeah, nobody likes serratus work. Yeah. It uses the obliques. It uses the hamstrings to hold the pelvis in position. But essentially what we're going to do is, this is kind of stolen from PRI. I wouldn't necessarily even do the push-up if this is someone's first time, but have them in an all fours position. And basically what they're going to do, knees under hips, hands under shoulders. I'll just move back. You're going to tuck the pelvis without dropping the sternum. Can I curse on here?
Yeah.
Fantastic. What I always tell people, if you're trying to tuck a pelvis, you're in a phone booth.
Oh.
Right? What I mean by that is, pelvis comes forward, sternum and head don't come forward.
Okay.
There's no movement here. You're in a phone booth, right? There's no forward movement up here. It's all just here. Okay. You can also go in a broom closet, whatever way you want to think about it.
Yeah.
But we're in this position. You tuck the pelvis, and just by doing this, you're going to shorten the obliques, the transverse abdominals, and you're going to turn off the low back. It's getting lengthened and inhibited. Yeah. Then all you're going to do, lean slightly forward. That's it. We would also, if someone has issues with their wrists, which a lot of people do there, especially if you've got a background in yoga, I love yoga, similar to what we did with the foot, you put as much weight as you can in the pisiform, this part of the heel of the palm, and have a little bit of contact at base of pinky, index, and thumb, but all the weight will be here. As you push through that, you'll feel the back of the tricep engaged, those serratus muscles under here we talked about. Mm-hmm. You'll feel the shoulder blades spread apart, and if you nail it, you'll get what's called posterior mediastinal expansion. Your upper back will expand this way when you breathe. Mm-hmm. Do you see me here? Instead of a belly breath, you'll see my shirt will billow out. Mm-hmm. That's where we want the air to go. We want the air to go this way, not this way. So the third one I'll do is fairly similar typically to the first one, but with a balloon, and the balloon sounds silly. I'll have them exhaling into a balloon and then holding it open, not pinching it off, and managing the pressure. Reason being, and this is, again, I told you these are not sexy, they're not cool. You do them in the gym, people think it's goofy, right? The biggest reason, and this is going to sound super controversial, the biggest reason in my experience people have low back pain is they breathe like That's it. If you take a big breath and everything comes up, great. You don't breathe well. What should happen when you breathe is we should get front to back expansion of the whole rib cage. If you're coming upwards, I'm going to use my trusty prop over here, right? What should happen, our diaphragm is supposed to live inside here like this, like two little domes, like a little McDonald's arch, okay? When we're exhaled, this is where it should be. When we inhale, it drops down. Exhale, inhale, exhale, inhale. This is kind of important for the pelvic floor talk later anyway. So if the diaphragm can't pull down anymore, let's say, for example, we're in that position we talked about, the anterior pelvic tilt, and those ribs are all flared out. That means the circumference of the rib cage has gotten bigger. So now that the diaphragm has gotten pulled and stretched, so it can't come down any further. It's already down and long and flat. Mm-hmm. So your choices are don't breathe anymore, which is very much a short-term strategy. It's not going to do too well for you. Or let's find a new way to breathe. And if we can't drop the diaphragm down, because it's already flat, what we're going to do instead is lift the rib cage up. And how we're going to do that, and if you're the person who has I carry my tension in my neck, you get neck aches, you go see the massage therapist, like, oh, you got that tight neck? It's because your neck is doing your breathing for you. Every time you inhale to elevate the rib cage, we're using upper traps. We're using SCMs, we're using scalenes, subclavius. And this is a complaint I'm hearing more often from women, actually. They're like, how do I get my neck to be smaller? I'm like, learn how to breathe. It'll get smaller. For guys, they're like, how to get my trap to connect to my ear. I'm like, don't worry, just keep doing what you're doing. It's on the way. But it's so not sexy, but getting used to using that balloon. And here's the whole hard part. Holding exhaled, not holding inhaled. You exhale, you hold exhale for 3 or 4 seconds. Again, it's a PRI technique. What that does is it actually acts resistance to the diaphragm. We have to learn how to overcome it. It's like doing the diaphragm is a muscle like any other. We have to learn how to basically accept the pressure and overcome the pressure by using that balloon. And every exhale we do into it is trying to force us again into a stronger position. So we have to keep working at it.
Would that be like
super not sexy?
Doing an eccentric exercise effectively?
God. Yeah, pretty much. Like I said, they're not sexy exercises, but eventually they lead to heavy performance.
We're going to come back around to that because I want to dive a little bit deeper into the breathing. But I want to talk about the 3 things that we should be doing in order to protect ourselves against lower back pain. We've talked about how to, if you tweaked it, on the weekend, you're a weekend warrior. If you're in a lot of, we talked about 3 things that you can do to mitigate against that, put length back in the lower back. But what can we be doing to prevent that lower back pain in the first place? Top 3 things.
Number 1, and again, going to be unpopular. For most people, stop stretching your hamstrings. Strengthen them instead.
Okay.
Like, strengthen your hamstrings as much as you can. Things like a hip bridge or a glute bridge, especially if you have low back pain, most people tend to go the full range of motion. Go the full range of motion you can without losing a tuck, and you'll get the hamstrings way more. You get less quads and less erectors. Yeah. If your quads and your erectors and your calves are super strong and tight, and they're mechanically advantaged because of the position, they can do all the work. You have to do a little bit differently to get it. Actually, a really nice one for that is, I've seen some hilarious videos of people doing this wrong, but leg extension machines, you can get in under them and actually use those as hip bridge if you're not super confident on like a barbell glute bridge or a barbell hip thrust.
Love that. Give me 2 other things. What should everyone
2 other things. Wear shoes that are appropriate for your foot. And this is a war. This is a war I have with people. If you're wearing, first of all, I'm not trying to say anybody shouldn't wear high heels. If you look great in them, fantastic, wear them. But if you have chronic low back pain and you wear high heels, you know exactly what's going to happen. You know it's going to hurt. It's not going to be a fun time for the next couple of days. So the key there is you got to earn the right to wear shoes. What that means is, like we were talking about earlier, once you start getting good at sensing, and it's not a sexy thing to talk about, but sensing that outside here when you're standing, and you can do it in good shoes that are supportive. What is a good shoe? For most, there are different shoe types. The Ruska Clinic and the PRI Clinic, they have a shoe list they put out every year, and they sometimes do it twice a year. You can, if you just Google PRI shoe list, it'll be the first thing that comes up. And it'll show you, yep, it's a fantastic resource. It'll show you the good shoe types for different arch types. If you're flat foot, normal to low, or high arch. That right there, wear those shoes as often as you can. And if you do that on its own, some people, that'll be enough. It's a small percentage of people, but some people, that on its own will be enough to make them feel better across the board. What we just did there, talked about when you get the sense of the lateral heel, the outside heel, it'll turn on hamstring. A good shoe for most people will hug that outside heel and give their brain more of a sense of it, so they start to automatically load it without doing a lot more. That can be such a huge step.
And one last thing to prevent and protect against lower back pain.
Oh, stop using lumbar supports on chairs. They suck. Like almost every chair you see, like the chairs that have like the big convexity here, it pushes out for a lumbar support. What it's doing is it's arching your back. A lot of them. They should almost have a lumbar cutout to put you in a posterior tilt, but they don't. A lot of them are just nonsensical. It's like someone one time decided lumbar support was a cool thing. Now everything decided had to bulge out. What that's doing, it's putting people in a position they're already great at, which is causing the issue. Yeah.
Which is basically like, pelvic tilt, and then also already in that kind of forward flexion.
Yeah, and then we're going to put the forward head in there as well. It's going to make everything as bad as you could possibly make it.
Yeah.
There's no difference between a standing desk, a seated desk. If you stand like trash and you also sit like trash, standing's not any better.
Got you.
So wearing good shoes, if you can, if you're sitting for a long period of time, try to make sure you can get good floor contact with your feet and feel the floor. If you can't, you can put something under your feet to raise the floor up. If you're a shorter person, you may have to do that. Or if you can't do that for whatever reason, or for example, you're on a plane, you can't be bringing a box around with you on a plane, what you can do is try to find your ischial seats. So you're trying to basically find some way to kind of like Obviously, you don't have just bones. If you do, it's a whole separate problem. But when you're here, you're trying to find pressure kind of like here-ish on the hips. So you can literally reach around, sit in your hands, and tuck your pelvis under and try to find it there. And as you do that, if you poke yourself in the obliques, these abs at the side, they will automatically have shortened and be a little bit tense. You're probably doing a pretty good job of sitting then.
Would you put like 2 wedges there for like just where, like if you were to say sitting on your hands, if I'm thinking about if I'm at my desk, I'm not going to be able to sit on my hands and do any work. But could I get 2 foam wedges, place them there because I'm automatically feeling that tuck already?
Absolutely. Actually, for some of my people, I'll do that when we're doing exercise. I'll get like a thick rolled up towel and I'll just put it right there, right under the back of the knees, and it kind of puts them out posterior tilt. Yeah, that'll help a lot of people.
What do you say to people who believe that lifting heavy weights is dangerous?
I say they're correct within a certain context. The number one thing I tell everybody is injury risk spikes when you do silly things, right? First of all, if you see me lifting 400, 500, 600 pounds, that doesn't mean you can do it. Anything, like when I train people and when I coach people, I tell them you should always take the smallest possible increment. Mm-hmm. So if let's say I'm deadlifting 570 and have a pair of 2.5s. If I'm going for my next record, it's going to be 575, not 615, because that's stupid. Mm-hmm. Like the higher up you go in strength, the more likely you are to get injured by small things, because there's a point where your body's just not going to be able to take it anymore. Also, people shouldn't train to failure as often as they do. Most people think they kind of have that 80s mindset of like, I got to smash myself into the floor and grind myself into dust. No, like the people who I know and who I've coached who are most successful long-term at not getting hurt and getting lean, fit, muscular, how do athletes train? They don't train maximally. You train, high frequency, moderate intensity. Some days, if you're not feeling it, you do low intensity, but the frequency is high.
I always say that as an athlete, everyone thinks that we're like 110% every single day, like hardcore grind culture. I'm like, it's actually not. It's more like 80% every single day for the rest of your life. And that's how you become, like, year on year, one of the best athletes in the world. And, that's certainly how we train clients down at Slay. Like,
beautiful.
It's a really interesting thing, I think, especially in the US. I tend to see that the culture in the US tends to dictate the way we go in terms of fitness across the globe.
Yeah, 100%.
Really interesting and obviously positive to see people starting to work more within their own realm of ability as opposed to where they think they should be.
I'd also say on exactly that note as well, Louise, if you're someone who wants to, test your maximal strength, do an estimated 1 rep max instead of a real 1 rep max. Unless you're a competitive powerlifter or a competitive Olympic lifter who actually has to know what their real max is, and even then you should be doing it close to competition. Google estimated 1 rep max calculator, and if you can do anywhere between 1 and 20 reps, there's a formula there so you can check it out. But you're going to hurt yourself trying your 1 rep max far, far, far more often than you are seeing how many reps you can do if you can do 15.
Yeah, love that. With our clients, my goal is to get them to reach like a good amount in terms of their 1 rep max within 1 year. But
love it.
2 months. Like the whole point, I think, is really putting in. I always call it like sweat equity. This idea. We also, as trainers, judge people's what we're going to be putting on their belt based on their 1 rep max. Well,
100%.
I'm going to bring someone in the gym as a novice athlete and start trying to get them to lift a maximum for 1 repetition.
God no.
Trouble.
But that's what a lot of people do every day. Like some people every single time they're in the gym, they're like, okay, I have to hit failure today, I have to hit max reps, and then they expect to get better.
Which is why we're talking about lower back pain. So, but for general population, are we talking about, is this an excuse, like weights are dangerous? Are we still in that era of weights are dangerous, or should we all be lifting weights?
I think we should be all lifting weights. And I'm also going to say something that's going to be very unpopular amongst a lot of fitness people, is that I think machine weights get a bad rap.
Go on.
For general population who do not have to go and perform in a field, they want to burn fat, they want to build muscle mass, they want to feel better, and they want to stay safe. Machines are fine. Absolutely fine. Are they as good as free weights for every single purpose? No. Are they better for some? Absolutely. Like, the right tool for the right job. For general population, I care about, will you adhere to the program? Will you enjoy it? Will you get hurt? Will you get results?
Yeah.
If those four things are satisfied, beyond that, I have no emotional attachment to the tool.
Yeah.
If you don't want to do barbell back squats, that's fantastic. We're not doing them. You want to do it? You want to do like a Smith machine bench press instead of a bench press? Not my favorite. I have a lot of reasons I wouldn't want to do it. But am I going to cry because you don't want to do the things that I want to do? No. I feel like a lot of the fitness industry, we have this thing where we project what we love to do on our clients.
Mm-hmm.
I don't care what they do so long as they're getting results. I really don't.
I think
Like,
also,
if they want to do simpler stuff, it's easier for me, in fact.
we're also living in a world where remote training has become, the norm, whereas 10 years ago, it just wasn't really,
Oh, yeah.
because of technology and the way things have really kind of
It's
sped
wonderful.
up. Kind of remote learning almost lends itself more to machines a lot of the time from a safety
Yep.
perspective and from a get in and get the basic lift done perspective. So yeah, I'm with you on that. I definitely feel like there's a definite time and a place, and for the right person. Here for it. Let's talk about stretching. Okay. This was a question that came up in the gym today. One of my good clients and good friends, Samantha, we were thinking about things that we could grill you on. And the topic that came up was stretching, because obviously lots of research about active and passive stretching. I think, I wouldn't even call yoga a fad. It's now become a lifestyle, etc. Where do you, as a physical therapist, personal trainer, stand on stretching? I think I know the answer already, but if you had, do you believe in it? Do you have a preference? Passive, active, dynamic?
So I've been misquoted several times saying I don't believe in stretching. I think, again, like anything else, it's a tool for a job. That's all. I will say as well, I'm not technically a physical therapist. I do all non-manual stuff. I do consult for physical therapy firms, but I'm a trainer who I do straddle the line. I work with both, but I'm not technically a doctor of physical therapy. So I want to make that clear. Where it comes to physical therapy, when it comes to stretching rather, it's a tool for the job. If you're acutely tight, for example, if you went for a run yesterday and your calves are jacked up tight, cool, stretch and go nuts. I love it. Use your Theragun, use your foam roller, use whatever you want, turn them off. Love it. More power to you. It's the exact right tool for the job. If every single day you wake up and your calves are tight, you're trying to treat a chronic problem with an acute solution. We need a new strategy, a new long-term, like we were talking about earlier, a new long-term automatic strategy, and I don't believe stretching is the answer there. Is that fair?
I think it makes complete enough sense. Pure and simply because I'm always thinking about, well, what is the root cause?
What does the general population think? Yeah.
Right. So I'm like, oh, well, why are my calves tight every day? Why are they being put in this shortened position? Is it the footwear I'm wearing? Is it what else is going on in my body to cause this? So yeah, I'm completely thinking in that dimension as well. But if I'm general population and I can't distinguish whether this is a chronic pain or just general tightness.
Yeah, of course. It's hard to sense these things.
What should I be doing every day? What should I be doing as a warm-up? What should I be doing as a cool down? What can I be doing to make sure that I'm keeping good length and tension on my muscles and being operating optimally?
So that's a great question. Number one is going to be what I would have most people do, unless if I've assessed them, they'll have specific rehab warm-up. It's like somewhere between rehab and somewhere between warm-up. So it might be, for some of them, it depends on the person. Like rehab for me is not the same as rehab for a 75-year-old Joe with the 5 herniated discs. Like rehab for me could be bench pressing 200 pounds. You know what I mean? Rehab for Joe might be, Joe, can you hold yourself up in that all forward position we just did?
Yeah.
So it's going to be definitely somewhat person specific. But for most people, the warm-up is going to be 2 or 3 drills or exercises to give them the ranges of motion they suck at, or to activate the position that they suck at and reinforce those. And then we're going to go and do a couple of warm-up sets of the lifts they're going to do. And then we're going to get straight into it. And we're going to try, and depends on how far along the rehab spectrum someone is. If someone comes in, they can't walk, they can't get out of bed in pain, we're not going lifting weights session 1, 2, 3, 4. It's just not going to happen. That'd be irresponsible. If they're further along and they're kind of in and out, they have occasional flare-ups, great. You can do the exercises to keep you out of pain. And then we'll try integrate those same principles into the weightlifting. And that's the big disconnect between physical therapy principles and training principles. Training, by and large, and again, I might get yelled at for this, it's stuck back in the days of everything has to be powerlifting and bodybuilding style. So you're Olympian again. You guys, you're not walking there and doing starting strength or, Louis Simmons or Westside Barbell. You're not doing tons of wide grip, big arch, bench press, and barbell back squats, the big 3 and heavy deadlifts. So no, it's not going to happen. It has to fit for the person. So For most people, I'm going to want alternating reciprocal movements. I say alternating reciprocal, and again, I stole that from PRI. So an alternating bench press could be this, left, then right. Alternating reciprocal means the joint on the opposite side and the contralateral side is doing the opposite thing. So when I drive the right arm forward, the left arm comes back. Humeral adduction, humeral abduction.
Yeah.
When, exactly, you know exactly where I'm going with this. Why I care about that, and this is a huge bone of contention in the fitness industry. They're like, oh, you're making things more complicated than it needs to be. Shut up and lift. It's all well and good if you're one of those people who doesn't get hurt, or if you're not looking for, absolute peak performance, if you're not going to be an Olympic level athlete. For everybody else, we could break down and classify movement, large gross motor pattern movements by side of the body as one of two things: moving towards a weight bearing position and moving away from a weight bearing position. That's it. We can break that down to a million different subcategories, but that's what walking is. When you land the foot, that side's a weight bearing position, the other side's swinging, it's moving, swinging, and it's moving towards a weight bearing position. That's it. Up, it's in weight bearing, moving towards weight bearing. Load, explode, compression, expansion, whatever you want to call it. There's a million different yin, yang, take your pick. But we can break down almost every athletic movement. So using a javelin, for example, right? That's perfect in a heptathlon. So perfect example of that would be your back leg when you're about to throw. The thorax compresses, the femur crosses midline, the arm comes behind, and then after you've thrown, that all swaps. It all swaps to the side. So I'm making sure they don't lose any of the prerequisite ranges of motion to do that perfectly. If they don't have them, I'm making sure they get them within that session. When I work with a bunch of competitive fighters, UFC guys, Bellator guys, that's what I do with them. And they're like, oh, this is not that difficult, but I feel stronger and faster, and my whatever doesn't hurt anymore. I'm like, yeah, cool. It's my opinion that it's the professional's job to know the things and be able to simplify them for the other person. You don't have to know all the things that I know. I don't care if you care about them. You just have to do it. If you feel better, that's the win. It's my job to know. It's your job to do.
I love it.
I do like nerdy clients, though. It makes my life better.
Well, I guess, it gets their buy-in, doesn't it? I want to talk about the emotional challenges of injury recovery, but also more importantly, take me back to the moment that changed it all for you with a client when you really knew that you had the power to help heal people.
There's been a couple. I would say, this is going to sound super egotistical. My problem was I came into the whole thing really injured. Like, the reason I really got into the rehab side of things, I loved the performance side of things. I was really focused on that initially. But I had been so jacked up. I had 5 TBIs, I had a cervical spine trauma, I'd broken half the bones in my body. And every time I'd been through physical therapy, I felt like something was missing and it wasn't coming back. So I started working at the Posture Restoration Institute and doing their stuff. I just found stuff made sense. I had a bunch of people who had low back pain for years. And I'm talking to these people 10, 15, 20 years. Like, one of the biggest ones was my mother-in-law. I was maybe 2 or 3 years into the rehab journey at that point. And I got this lovely lady who'd been essentially, a lot of her social life had been limited. A lot of her activities that she wanted to do had been limited. But in fact, she had this back pain. And 30, 40 minutes, and she's like, oh, it doesn't hurt. And I said to her, it's not going to stay that way. You got to do the homework. But, and this is the thing, you have to do the homework. Nobody can motor learn for you. I can't stress that enough. Nobody can do the work for you.
Absolutely.
But that was one of the biggest ones for me. That's the reason I get out of bed. My wife will tell you, I'll work with someone for a couple of weeks, whatever. And when I get to discharge, I'm like, hey, you don't need to see me anymore. I have tears in my eyes. I'm so happy. Some of the messages I get thank you cards. But it's like, and I'm not trying to take away from the other things. Like, I love getting people lean. That's cool. I love getting people strong. That's cool. I love working with professional athletes. Professional athletes I really love with, because I have a soft spot, because I feel like I missed the boat on that. So I want to help people who didn't miss the boat. But really getting someone from a hard rehab position and seeing them understand that, I guess if you've never been in chronic pain, you might not know what I'm talking about here, but if you have a family member who is, if someone just clicked their fingers and made it really easy for them to not be in pain anymore, seeing the hope come back in someone's eyes, that's cool. Like, there's no feeling like it.
Special.
Yeah. That gets me out of bed after 9 a.m. Yeah.
Let's talk about pelvic floor function. But not just pelvic floor function. In the gym, we've had 5 sleigh bees, I call them, sleigh babies, this
Fantastic.
year. And so pelvic floor function, I would say, is an area of expertise that I feel like we know so little about as personal trainers. I feel like to find
Oh
a good
yeah,
course or to find a good expert to relay information. But you've not just been using pelvic floor function for like pre and postnatal clients, you've also been using it for men, which is something I've never heard of. So
oh
first
yeah,
and foremost, let's talk about female pelvic floor function. What should we
sure,
be doing? um, and what should our understanding of that look and feel like? And then I want to know about how you've been using that with men as well.
cool. So you can see I got a bunch of props around here. Um, so the pelvic floor, guys, if you don't know, lives in here. It's made of a bunch of different muscles: puborectalis, iliococcygeus, coccygeus. You got the levator ani in here. You've got a couple more bits and pieces, right? For most of you, you don't care. You just know it's a pelvic floor. I would say we're better off thinking of it as a pelvic diaphragm. It moves up and down and should do so parallel to the respiratory diaphragm. It's very important to this whole thing. So this is why I talked about this earlier. If this bad boy isn't coming down and up like this, the pelvic floor won't either. Those two work in parallel to one another. If you have a rib cage that's big and flared and a pelvis is anteriorly tilted, it'll make it real obvious. If I'm trying to shorten these muscles and give them a little more strength because they're long and weak, right? Which is, if you're trying to strengthen the muscle, we want to shorten it, right? If this pelvis is anteriorly tilted, I'm going to show you guys from here. If you just look at the space between here and here, I'm going to anteriorly tilt. Now you can see these guys come in, but this might be hard to see. Can you see the space in here has gotten much bigger?
Yeah.
So as that pelvis rotates forward in space, that anterior pelvic tilt we talked about earlier, your pelvic floor muscles for the most part are all long and weak. Not a whole lot you can do about it until you fix that pelvis position. Position first. Position dictates tension. And fix the breathing, because if every time you breathe, you're getting pulled up, that's also going to rotate the pelvis forward. So I would go out on a limb and say, and again, I think I yelled at for saying this, if you're trying to address a significant pelvic floor dysfunction or pain or issue without addressing breathing and ribcage, you probably don't understand how the pelvic floor works.
Got you. Talk to me about what you should be. How do you know whether you've got a strong or weak pelvic floor? As you're talking the whole way through this, by the way, I'm just like breathing.
No, of course.
Drawing in. I'm doing all the things.
As part of my screening, I ask people this all the time, and people get really weird. I always know as well beforehand pretty much who has this. I can usually eyeball it, but I'm always a bit sensitive about it, and it depends on the human being how I ask it. If we're going down this checklist and you're telling me some things, I'm like, okay, I already have suspicion of pelvic floor dysfunction. I'm like, hey, when you laugh, jump, sneeze, do you pee a little bit? Yeah, how'd you know? You said this experience last week. I'm like, okay, the next question, which is a much more personal question, and I definitely will not ask somebody on a first session unless we build up quite a rapport with a very open human being. I'm like, great. Is it really hard for you to orgasm? Because it's a pretty big correlation between those two things. The pelvic floor for men and women is very important for sexual function as well as urinary incontinence and as well as athletic performance. For women, like the G-spot goes the whole way forward into the clitoris as one like cylinder of nerve tissue. So if the pelvic floor muscles which it passes through are long and weak and they're basically stopping sensation transfer from one side to the other, it's going to be really hard to orgasm. The pelvic floor muscles are heavily involved in orgasm. So if they're long and weak, you might be entirely anorgasmic, or you might just have orgasms. You might find it really hard to get there. And your poor wife, husband, boyfriend, girlfriend, whatever, they are working hard. Make life easy for them.
Putting the work in.
Yeah, exactly. And that's the same thing there. We're going to have pressure on our bladder. We're going to have urinary incontinence potentially as well. If you say yes, one or both of those questions, I'm like, great, we probably have pelvic floor dysfunction. Now, of course, there could be other physiological issues that are medical that have nothing to do with what I can do. So I'll usually ask them some qualifying questions on those. If in doubt, by the way, and I can't stress this enough to any professionals watching, if in doubt, ask for scans. If in doubt, rule out other stuff. We could get, I've had a lot of interesting ones there where I'm like, this seems like something I can help with, but there's something off. Get scans, get data. You can never have too much information. That's what I always say.
If I'm sat here now as a listener, how do I know that I'm activating my pelvic floor? Like, take me through like a 3-step guide right now.
Let's do it with you. That's perfect. Okay. So we're going to get you some iliococcygeus and coccygeus. This is a bit tricky to do. I wouldn't typically start something here, but because you're sitting already, we'll just do it this way. We'll start off on the right side. Most people have more left pelvic floor dysfunction than right. It's much more common. Not getting into the reasons why. It's beyond the scope of our conversation today. It's a long, nerdy conversation, and I love it, but no one else cares. So what we're going to do is I want you to basically bring your left knee towards your right knee. So bring the whole leg so almost the knees are touching. So you'll be kind of like Again, it's hard to see because I'm wearing black pants. I want
Yeah.
you to tuck your pelvis, and I want you to pull your left knee so it's slightly behind the right knee while keeping that tucked pelvis. Okay?
Yeah.
Now what I want you to do is, you're going to imagine like you're holding a marble between your knees. This is modified from PRI exercise. You can imagine like you're holding a marble between your knees. You're going to feel that inner thigh on the left side already.
So crazy.
Yep. Now what I want you to do is inhale and slowly pull that left leg further back without dropping the invisible marble. So don't let the left knee come outwards at all. So you're going to keep that tuck. Yeah, you might feel like deep into the groin fold in here after a breath or two.
Yeah.
Yep. So give me 3 or 4 of those and get progressively further back in each inhale. It's not going to go very far back. Keep the weight in that left butt cheek. It'll get deep into that groin fold, and you get that adductor lighting up as well, that inner thigh. So progressively further, yeah, it's tough.
This is going well tonight.
So it's one of those things where once we're good at regulating the pelvis, then we can get a good pelvic floor function. But you can't, it's kind of obvious when you say it like that. If we can't regulate the pelvis, we're not going to have good pelvic floor function. So if we can't get the pelvis to get out of that anterior tilted position, they're pretty much always going to be long. It's tough, right?
It's just my doctors are absolute crap at the minute. They're just
That's it. If we don't have strong adductors, it's very hard to have a strong pelvic floor. Very, very hard. And that's a huge part of it. Postpartum in particular, again, I'm not trying to be not trying to be rude to physical therapists or pelvic floor therapists, but postpartum, the typical procedure I get most people here getting is to get either intraanal or intravaginal manual work, a little bit of Kegels, which is levator ani. It's not those muscles just working. Nothing respiration, nothing changing rib pelvis relationship. And then it's okay, you're discharged, great, go ahead. And there are some phenomenal manual therapists out there. It's like trainers. There are some amazing trainers. There are a lot of crap trainers as well. Same thing with physical therapists, same thing with pelvic floor therapists, same thing with every profession. The bad ones, unfortunately, in any profession, the ones that are not great are more common. So if you're someone who's postpartum and you're having these issues, they're not permanent issues. They don't have to be. They really don't have to be. You shouldn't have to, I had a client this week who I talked to, say she wants to jump on a rebounder with her kid. Because kids love doing the rebounder. A little bit of exercise. I said, well, I can't do it without wearing a urinary cup. Yeah. I was like, oh, that's, we shouldn't have to do that. I had another lady, lovely girl, I can't give too many details because the whole lawsuit. She was involved in a hit and run. She got hit by a van, broke her femur, her pelvis, her ribs, fractured her skull, broke her arm. Oh. Yeah. And I had seen her post-acute rehab. So she was discharged by her acute physical therapist. They sent her to me to help with the repatterning. And 2 or 3 sessions in, her back pain's gone, her shoulder pain's doing good. She does her homework. She's an ideal client. And she kind of comes up to me and she says, Rua, this kind of conspirational lean in. I said, the only time someone leans in like that is they're about to say something very embarrassing or they're about to tell a really, really inappropriate joke. I was like, she didn't have a smile on her face. I'm like, all right, so it's the other thing. I'm like, I have something to ask you. I was like, I think I know what it is. I was like, you having trouble orgasming? And she's like, yes. I was like, all right, cool. We did some of these modified pelvic floor exercises. She came back 2 weeks later with the biggest smile you've ever seen. Just ear to ear. I said, guess what? I was like, I don't have to guess. It's fine.
Yeah, it's not written all over your face.
Exactly. Now, for the guys watching, being like, well, I don't care about pelvic floor work. I want to get gains. Cool. I get that.
Pelvic floor for guys, are they doing the same exercise or is it something
different?
Yes.
The pelvic floor is fairly identical, to be honest, from male to female. It's a little bit different, but not a whole lot. But for guys, the blood supply to the penis goes through the pelvic floor. So guys who are in your 20s, enjoy it while it lasts. I was going to say everything gets harder as you get older, but that's the exact opposite for most people. So if you're having trouble, harsh but fair. If you're having trouble in that department, before thinking about going on medication, obviously there can be psychological issues, there can be other physiological issues, there can be blood sugar issues. And again, I'm not discounting that. But if those things have all been taken care of and cleared, great. It could be pelvic floor dysfunction. And I've seen competitive athletes, male, in their 20s with high testosterone with erectile dysfunction because their pelvic floor was so badly messed up.
So have I.
Yeah, I'm so sorry. It's one of those things, that's not as a, in the prime of your life, that's not something you want to be dealing with. It's got to suck for the ego. It's got to suck for everything else. Also, in most people with sciatica as well, the pelvic floor is somewhat implicated too. So the pelvic floor is going to change the relationship of the ilium to the rest of the coccyx. And it's going to help with that, regulating that, because the sciatic nerve travels back behind the kind of the posterior part of that ilium. And that's also got a crapshoot. It's not fair again. Some people can do silly stuff and get away with this, but some
Yeah.
people have a bifurcated sciatic nerve, it's like 2 branches. Some people have 3. I've seen some reports people have the 4. It's just one of those things where if you get unlucky and your pelvis is rotated the whole forward and you hit all of these criteria and a couple others, cool, you got sciatica. If you ever had sciatica, guys, it is horrible. It is debilitating. So typically, pelvic floor work will help with that, in my experience. I've had a lot of sciatica cases get fully resolved with that. Fully.
Rua, we're going to wrap up now with a quick game. It's called Broke or Woke, i.e., are these things just straight out broken, or are they woke and should we all be doing them?
This is what I'm going to get in trouble for.
10 or 11 quick fire questions. You're just going to give me an idea. Broke if it's crap, woke if it's good.
Let's do it.
1. Infrared light therapy.
Woke.
Excellent. Ice baths.
Ooh. Broke for me. Borderline, but.
Why do you say that? Give us a very brief.
Most people are using them wrong. If you use them post-exercise, they limit muscle growth and recovery. If you're doing it first thing in the morning separately, different story. They're using the wrong tool for the job. That's all.
Chiropractic adjustments.
Oh, you're killing me here. I'm going to say broke with an asterisk that I know some amazing chiros. Nobody can teach you how to move. You have to teach yourself and learn yourself.
I get the impression that you obviously use much more hands-on therapy.
I do all non-manual. I don't put anyone in any position. I teach you how to move yourself, and then you do it.
Got you. Foam rollers.
Broke.
Broke. Not
Broke.
foam rollers. Oh, why not?
It's just inhibition. Again, it's all context. If you're tight from yesterday, awesome. If you're trying to use it every day to fix a problem, it's not fixing a problem.
Got you. Massage guns.
Same thing.
Same thing.
I was saying, bro, I have one. I have a foam roller. I have a massage gun. They get used maybe 5 times a year.
You're going to love the next question. Passive stretching.
Passive stretching. I'm going to say woke, controversially. There are times it's appropriate. And some people just love it. If it gets you in the gym, awesome.
Got you.
Just not hamstrings, most people.
Goat yoga.
just because it's hilarious, woke.
Nice. HIIT yoga.
Absolutely broke. So broken.
So me and Eric always had this conversation. He's like, HIIT yoga, basically the benefits of neither.
Yeah, okay. It's 2 birds and it's like 2 stones and no birds.
Now this is one I threw in there. Pistol squats.
I like a shrimp squat better than a pistol squat.
What's a shrimp squat? Like this?
Shrimp squat is like foot behind you, like that. It's like a 1-legged squat. I'll do a crappy one. Hold on a second. If I rip my pants, it's your fault.
We can't see. Let's go. Oh, you sicko.
Yeah, those I'm here for all day. Pistols, most people just go into extension and they turn what should be an asymmetric movement into a symmetric one and just wedge themselves there. Or you have people who have like ligamentous laxity abusing their ligaments to drop down into it, like some weird contortionist.
So the general population, broke or woke?
Definitely broke.
Okay. Deadlifts.
Say again?
Deadlifts.
Oh, I'm going to say woke. I love deadlifts. Love them. I think everyone should be able to lift that way. I'm not saying necessarily what form or what implement to use, but it's a lift you're going to have to use in general life. You're going to have to pick stuff up from the floor. You got to be good at it.
Absolutely are. Barefoot training to finish.
If you're outside on uneven surface, it's so woke. Otherwise, I'm going to say it's broke.
Outside, uneven surface.
Yeah, get on some uneven like grass, like not outside on pavement. Feet, like the whole barefoot movement to me, it's a scam. I'm just going to go ahead and say it. We should be barefoot 100%. And that would be great if we started pre-puberty and didn't spend, half our life walking on flat surfaces, staring straight ahead. But we did, so now we need shoes. If you were outside barefoot the whole way through your development, you probably wouldn't have any issues with feet, probably a lot less issues with low back, hips, pelvic floor. But we're not, so you got to kind of live in the world that you live in.
Got you. Need some assistance.
Plus, Vibrams are the ugliest shoes in the world. They are so broke. They're so horrible.
hopefully something else will be developed.
If you like
um,
barefoot shoes, zero look nicer.
what's it?
Zero, Xero. There's like, I don't
Zero.
like them at all for 99% of people in terms of support, but they look way nicer.
Got you. Love that. Rua, that concludes our podcast. Thank you so much for joining us. So much information. Absolutely love it. You're an absolute fountain of knowledge and
Thanks for having me.
experience. I really appreciate it. Feel free to stay in touch with us. We'll start implementing some of what you've said. Obviously, zero barefoot shoes in the Slade gym. See how we get on with that. We'd love to stay in touch with you. And yeah, absolutely, absolute cracker.
Much appreciated. I hope I didn't insult too many people.
No, and we'll find out. All right, Rua, have a great day, darling.
Thanks, Liz. I'll see you later.
That concludes this episode of Slay. Stay tuned for more empowering discussions on female health, fitness, and life. You can follow me at Louise Hazel on social media, and you can follow Rua at The Biomechanist and check out his work at Boa Fitness, that's BUA fitness.com. You can check out the Slay brand now at Slay Athletic, and don't forget to subscribe to the Slay podcast if you haven't done so already on YouTube and leave us a review. You can also get all the tools and resources from all of our podcasts on the Slay app. Download it now for free from the App Store and join our online community.